I would, uh, for the audiences, I would like to begin with our next session. That is a panel discussion on using digital technologies to achieve equitable, accessible, and affordable healthcare for all. This panel comprises of experts from diverse backgrounds in healthcare ecosystem. We have with us Biten Kathrani from Johnson & Johnson, Sunita from DELL EMC, Ajay Seth from Philips, and the discussion would be moderated by Dr. Vidur Mahajan from Center for Advanced Research in Imaging, Neuroscience, and Genomics. I would like to quickly begin with some introductions. Uh, First of all, I'd like to introduce Biten Kathrani. He is currently the head of R&D for Asia Pacific for Johnson & Johnson Vision Care. Based in Singapore, he represents APAC region in the Vision Care R&D leadership team and is responsible for developing and leading R&D programs, partnerships, and innovation in eye health in the APAC region. Biten has been in the healthcare medtech industry for 25 years, leading R&D, innovation, and new ventures in APAC and USA. He has led medtech R&D organizations in Asia Pacific for Johnson & Johnson and Boston Scientific. He has been instrumental in setting up APAC R&D centers for Johnson & Johnson surgery businesses in India and China and Boston Scientific's global R&D center in India. He has been proponent of design thinking and customer needs and insights-driven innovation and has been associated with the Stanford Biodesign program since 2009. Next, I would like to introduce Ms. Sunita Nadhamuni. Sunita is head of digital life care at DELL Technologies, building the technology system for Ayushman Bharat's NCD program for management of hypertension, diabetes, and common cancers. As technology partner to Government of India, her innovation team is enabling the digital transformation of public healthcare services at population scale. This is a social impact CSR initiative of DELL. Sunita has a unique combination of more than a decade of IT experience from the Silicon Valley in the US at companies like Sun Microsystems, SGI, and Healthion, WebMD, and a decade in India leading social impact initiatives. She was also the founder of Argyam, a leading charitable foundation on water and sanitation in India. Next, I'd like to welcome Ajay Seth. Mr. Seth is the Innovation Portfolio Manager at Philips Innovation Campus, Bangalore. He has been working with Philips for the past 20 years and has held various leadership positions globally and locally. He has been driving the evolution of mobile and IoT technologies as they intersect with healthcare, consumer products, and smart cities. Mr. Seth has also been involved in defining new business models and defining MVPs for digital propositions, enabling common architecture definition and software development across embedded mobile and web platforms. Lastly, I would like to welcome Dr. Vidur Mahajan. Thank you so much, Vidur, for moderating this session. Dr. Mahajan runs CARING, the Center for Advanced Research on Imaging, Neuroscience, and Genomics, which works with more than 30 research groups across the world and aims to bring cutting-edge products in the artificial intelligence space into clinical practice through its platform called CARPL. It is world's only platform for the development, testing, and deployment of medical imaging AI in clinical practice. CARING has published several papers on AI, including the first paper on AI in the Lancet, and has more than 100 academic and conference papers in the field across the world. He is also additionally responsible for running Mahajan Imaging, one of India's leading medical imaging providers, and CARING DX, an advanced molecular diagnostics lab. He has done an MBA with dual majors in finance and healthcare management from the Wharton School of Business and did MBBS from Lokmanya Tilak Municipal Medical College, Mumbai. A very, very warm welcome to all the panelists, and I'll now hand over to Dr. Mahajan to get started with the discussion. Thank you.
Thank you so much, Irfa, and thank you so much for this opportunity to the entire HitLab team. Welcome, Biten, Sunita. Ajay, I think, has some technical issues. He's just joined right now. Welcome, welcome, Ajay.
Thank you.
It's indeed very appropriate time to be talking about digital technologies and how they can bring down cost, improve accessibility in an equitable way. We've all I think seen the profound impact of technology during the COVID pandemic, including the very fact that this conference, which used to be a very physical conference, is now online. And everything from that to the very fact that I guess almost all doctors in India are now disseminating care over WhatsApp, if not the more complex telemedicine platforms that are out there. So it's we have about an hour and a half. I'm not sure, Irfa, how we will be taking questions, but please do, the audience, please ask questions. We aim for this to be very, very interactive, for it to be a discussion. And we have three very diverse individuals here, from diverse backgrounds, working on the same goal, interestingly. And I guess to start off with, maybe we can go around the table and share some, preliminary thoughts on how you feel, digital health, digital interventions, or digital technologies are playing a role and can play a role in the broader goal of ensuring equitable, accessible, and affordable healthcare. Sunita, ladies first. So I'd urge you to begin, and then we'll take it from there.
Thank you, Vidur, and really happy to be on this panel with all my co-panelists. Let me maybe, Vidur, if I could take a couple of minutes and just talk a little bit about what we do, so that kind of sets the context.
That would be very, 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 very helpful as well, of course.
Yeah, thank you. As Irfa read out of my intro, I'm leading a CSR initiative within DELL Technologies. And our initiative is called Digital Life Care. It's a social impact, social innovation initiative. And basically what we've been working on for the last 7 years is developing IT systems for digital transformation of primary healthcare services. So specifically focused on government healthcare services. So in the context of India, for the last 3 years, we've been partnering with the Ministry of Health and Family Welfare on the Ayushman Bharat Health and Wellness Center program. And this really progressive, ambitious program is looking at setting up 1.5 lakh, that's 150,000 health and wellness centers, primary healthcare centers, that are going to deliver a range of primary healthcare services to the population at a universal scale, right? So every single man and woman, every child is going to be covered through these basic primary healthcare services, ranging from maternal child health to immunizations and communicable diseases, and of course non-communicable diseases, to the entire population. And we are partnering with Government of India on one such program for the preventive screening, treatment, and management of non-communicable diseases at population scale. And so we've developed the technology platform to help government deliver these services. And so as we talk further on in this program, we look at what are the challenges in getting this equitable, affordable care to all, and how technology can play a role. And so our experience with partnering with government, over the last 3 years, we've rolled our technology platform out in about 26 states, and we have about 70 million people enrolled in this system. And so a lot of experiences, a lot of learnings that I'd love to share during the course of this.
Just like to reiterate that number, Sunita, it's literally, it's almost 5% of India that's already, on your platform. So just wanted the audience to digest that point.
Yeah, this is a government program. We are the technology partner developing the software, but of course it's a complete government program. And we're working along with Tata Trust to help deploy this software system with state governments. So that's my background. I'm a technology person by background. I have a team in Bangalore, and looking forward to the panel.
Nice. Thank you, Sunita. Biten, you could go next. Brief, maybe an introduction of what you've done over the past so many years, and how it relates to digital technologies.
Sure. First and foremost, thanks to the organizers at HIT Labs. It's always a pleasure to be back here. Had the opportunity to be at 2 of the past sessions in person. As Vidur, you pointed out, we live in a different world, but yet it's a pleasure to connect. So thank you to Stan, Irpa, for the organization and the invite, and Vidur, thanks for agreeing to moderate this discussion. And it's a pleasure to connect with you, Sunita and Ajay. Let me start by saying, I'll not spend a lot of time on reintroduction, because I believe Irfa humbly put me in a great spot in terms of her rich words on introduction. But I'll just elaborate on a couple of things. In my 25 years in the medical device industry, there are two things which have always been my passion. Number one, obviously, bringing impact to patients and their families, but more importantly, bringing that impact to the emerging world, which has had challenges in terms of not just affordability, but more specifically in terms of access and awareness as well. So everything I've done is all about bringing innovation in that context. Over the last 7 to 8 years of my career, I have embraced and been instrumental in developing multiple digital mobile health platforms through my teams, which I've led, to bring not just innovative solutions, but accessible solutions which can fill the gaps in the current healthcare. And I'm doing so in my current role as well. In my past roles, I've worked in the areas where digital technologies have been applied to cardiovascular, urology, endoscopy areas. Currently, in the last 2 years, I've been working in the vision field. I would say, in the context of the topic today, the answer of why should we be thinking about digital health lies in the key question itself, Vidur, which you posed, right? Equitable health actually means in itself that the healthcare is accessible and affordable without constraints in an ideal world. But it's also a no-brainer to say we don't live in an ideal world. And access and affordability are challenges. The question always has been, how can you use digital as a technology, as a platform, as a service, as a product or a solution combination to fill the gaps and remove the constraints which exist today in terms of access. And most of the access constraints have been associated with either lack of infrastructure, which Sunita reasonably touched on earlier. They've also been driven by the lack of access to trained healthcare professionals. And the also been an issue because of a lack of a business model which disallows investment. And then, of course, affordability is all tied to that. When access is a challenge, the sizes and the scale is very small. And we all know that emerging markets pay a heavy poverty premium because of our small numbers. So we can keep talking about our billions of population, but the population which is actually consuming healthcare or is able to consume healthcare is so small that we end up all across the classes of the society paying a poverty premium, which makes then healthcare unaffordable. And digital therefore has that opportunity to bridge those gaps in access. And as the scale goes up, and as the non-value adds are removed from the system, that's what allows it to be made affordable. So we certainly won't jump immediately into that ideal world, but definitely can come close to that.
So Biten, that's a beautiful point that you bring about, right? About technology being almost the equalizer, right? And I personally think about that a lot, right? Because if you think of it, right, one of the goals of life is entertainment, right? And because of mobile being all prevalent everywhere, the the rickshaw driver on the road is experiencing the same form of entertainment that probably the richest person in India is, right, on Netflix or whatever. So or they have this same access to search, same access to maps, same access to everything, WhatsApp. So but in your experience within how you've built hardware, you've built digital interventions also, right? Especially in your previous roles. How is it different as a company that's looking at, making sure, like something like distribution, right? So how do you guys think about that? This is, just more my curiosity, but like, you're getting stents out in one way, and at the other side, you're maybe building an app for cardiovascular disease monitoring. How do you guys think about that in terms of, the whole equitable part of things?
Yeah, so I may not be able to bring out specific examples
Yes.
because of confidentiality aspects, but let's talk a little bit in a broader way, right? If you look at the classic healthcare industry, be it pharma or medical devices, right? They've been a classic product-centric industry. It's service or value-added service beyond the product has always been a challenge, and it has been very unique in terms of its how it fits into the business model. The capital-intensive industry or the hardware industry, be it diagnostics, be it imaging industry, is a little more amenable to the solutions space, because their model warrants them to provide a hardware and then provide services associated with that, be it consumables, be it preventive maintenance for the equipment, right? So that business model allows them to add that. When you look at therapy companies, where you're either making instruments for therapies like surgery, implants, etc., it's so much focused on a pure product-centric approach and more a consumable approach on the products, right?
Yes.
So when I say consumable, it's not about being low value, but consumable as in it gets used in a particular procedure for a particular patient, and then it's gone for the next one. You need to open the next pack, right? If you have an implant, it's gone and consumed for one patient. So bringing digital into that, and how do you bring value add? That has always been the biggest challenge. And there is always this mindset, right, that internet is free. So anything is digital and not tangible, you cannot touch. Again, brings that mindset that it technically should be free. I'll give you an example. When you talk about cardiac implants like pacemakers, right? I don't know if most people are aware, but if you look at that industry in healthcare, people will pay for Apple Care when they buy their Apple phone. People will buy an annual preventive maintenance for their car, but they are not willing to pay a maintenance cost for the pacemaker, which is keeping them alive. So for a company which is making it, can you imagine that how short the euphoria is? You sell the product, it is implanted, so you gain revenue, and then for the life of the product, you're maintaining it for free. So is it an asset or is it a liability?
Correct.
Right.
So yeah, that's entirely, we could go down that path of how people think and make like.
So in a nutshell, it's a problem yet to be solved, but it's all about demonstrating value. So digital in itself is not. I don't think the digital world has a challenge of technology. The technology is there, it exists, it's been around, it can be done, unlike many other spaces. But here the challenge is around the business model and what value is it delivering for the stakeholders.
Correct. No, thanks, Biten. We'll quickly move on to Ajay. Ajay, could you share, some of what as specific as you can get, of course, given the constraints that we operate in. But what kind of work do you do at Philips, and how does it relate to the theme, and just your general thoughts on the subject?
Sure, absolutely. Thank you again to the co-panelists. I think great insights. So I'll probably try and avoid what has been said and keep it as unique as possible. First of all, I represent Philips, which has a very inspiring vision of touching 2.5 billion people every year and helping improve their lives, which is something that keeps us all going. And that is what has been our work almost on a daily basis. I basically take on the role of an innovation portfolio manager, making choices where we can have maximum impact, look at new business models from digital and cost point of view, as well as look at emerging world, be it India, Africa, Middle East, Japan, and the Eastern geographies in the work that I do in combining products and informatics to build possible solutions. Effectively, everyday job and in general at Philips, we look at healthcare world through the lens of a quadruple aim. And the quadruple aim basically is about reducing cost, improving patient experience, improving provider experience, and at large impacting the population health. We can of course during the discussion go into details of each one of them, and I'm sure it will get touched upon it. But I think fundamentally what we see is that the world is moving more and more towards a digital future, which is always on, responsive, and patient-centric. And in my view, I think there are three fundamental things which are driving this and will continue to drive this. At the base of it, it is the processing power, storage capacity, and the data transmission capability, which is effectively exponentially increasing between 9 to 18 months. And these are governed by three digital laws, which is the Moore's law, Butter's law, and the Crider's law, which is at the heart of the digital transformation that we are also seeing in healthcare. And I think today, as the subject entails, if you look at telehealth, which is making the field very level playing, the same three things are at the base of it, which is making the life of clinicians and the patients much more accessible in everything that they do. So looking forward to a great discussion, but fundamentally looking at innovation in the emerging geographies and possibly learning from fellow colleagues here is what I would engage in the rest of the discussion. Thank you, Dr. Vidur.
Thank you, Ajay. And it's amazing that you just rattle off countries so so seamlessly, and the very fact that you're building so many things for such wide geography is quite heartening, and quite cool, for lack of a better word. So I think you're just going a little bit more now into specifics. So Sunita, you mentioned when we were talking before the panel that while it's good to talk about equitable, affordable, accessible care, and we all kind of know how what it means. It's the how part, and especially the whole infrastructure side of things. You alluded to it briefly a few minutes ago also. Could you talk more about that? Like how would this, what is the technology backend that is needed to ensure that patients truly get the type of care at the time that they need it, in the form that they need it, right? So I know you have thoughts on that. It would be great if you could spend a few minutes and walk us through some of those.
Sure, thank you. Yeah.
The plumbing, as you had called it. Sorry.
The plumbing, right. So if we were to look at the digital transformation journey that the country's been through over the last decade, I think there are a lot of lessons to be learned from that, right? Starting with Aadhaar, that made gave every individual an identity, and with that basic building block, once every individual had an identity, it just kind of unleashed, all the power of multiple sectors, because then once people had an identity, then the whole through UPI, you had financial inclusion, because people could start getting loans, people could get could do banking. So for the unbanked, the large number of unbanked, UPI suddenly made everything accessible just through your mobile phone, right? And all of that started off with the basic building block of having Aadhaar, and then based and top of that, eKYC, all of those initial barriers that prevented people from accessing formal credit, formal, the banking sector, suddenly were not issues anymore, right? And we saw a similar kind of transformation. So this transformation of the financial sector, powered completely by this digital infrastructure, is, I think, one of the most, marvelous things that has happened to the country. Similar such transformation happened in the GST, the goods and services tax, right? That network. that. And then similar thing has been happening in the e-governance space across multiple cities as they all move to digital for property taxes, for birth and death registration, for grievance redressal. All of those are now going digital. And so how citizens interface with their city, how citizens interface with their government, how citizens interface with the education sector. So children, there's a lot of transformation happening in the education sector. Basically, the model that's being followed in many of these nation scale digital transformations is the same, where the approach is saying that we go with building the rails, the digital rails, on which you have the layers specifically for that sector. And then at the top, you have, so it's a layered platform approach. Right at the bottom, you have the building blocks like Aadhaar, and these form the digital rails. And then you have the sector specific, common functionality. And right on top, you have the apps. And so once you have this kind of layered approach, and all the heavy lifting is done by the digital infrastructure. So, things like, how are you going to get authentication and security and privacy and performance and all, the registries and consent. Once all of these are built into the digital infrastructure, it's like, a physical infrastructure. Once your roads are built and your drains and all the plumbing and the street lights and everything is set up, people can come in and set up their companies and set up their homes, and then you suddenly see a multiplication of, you see growth, you see, a lot of magic happening, right? It's the same thing in the digital world. So once you have this digital infrastructure built that does all the heavy lifting of all these core modules, then the app developers, suddenly you've just unlocked the doors, and then people can come and innovate on top of all of this. They don't need to worry about, how am I going to be interoperable? How are you going to exchange data? How are you going to make sure it's secure? How are you going to make sure the right person has access to the right information? All of that stuff is just taken care of, starting with identity, right? So we are looking at something similar. We, meaning, I think, the larger health sector, we collectively need something like this for the health sector, and on top of which all this innovation can happen, right? And that has been being talked about for several years now, and over the last couple of years. And the national health stack, and then the national digital health mission was set up, and then it was announced by the prime minister earlier this year. And that's now very close to becoming a reality. And so the basic modules that the digital NDHM is talking about is identity, consent, electronic health record. And once we have that kind of infrastructure, I think that a lot of, that's basically the foundation, the plumbing, based on which now a lot of innovation can happen. So startups and entrepreneurs and research labs getting access to the data, all of that can happen once you have this plumbing in place. So I think, to me, that's kind of the prerequisite. And I think that we're making tremendous progress as at the sector level in actually getting that to happen.
No, that's that gives me goosebumps, honestly, with the way you spoke about NDHM and the layered approach. The only thing is, and just pushing a little bit on that thought, right? The and I, for one, myself draw comparisons between NDHM and UPI and Aadhaar and all of that. But the fundamental truth is that the number of interactions I have with UPI, as or the number of times I need to pay someone or receive money from someone, is exponentially higher than the number of times I have to receive healthcare. Right. So how do you guys think about that? Right. Like, do you have any thoughts on that? Like, what will be the the incentive on the healthcare provider side is being discussed widely, but for the audience here that's looking at building applications or building tools using the national health stack with the NDHM as a base, how should they think uh, about this whole issue that I may need to interact with the health system once a year, and for that, will I truly download an app and give consent and then go through the entire process? Like, do you have any thoughts on that?
Yeah. I think that that's an interesting question. The way to look at it is that today these things are very, they're very siloed, right? So what we are not seeing is, since people don't have the flexibility, they're not able to they're not able to completely realize the full potential of what the health system has to offer. And again, we keep talking about, there are actually two Indias. There is the India, which is, people like you and me who get to choose, which kind of system that we want to go to and pay out of our pockets or whatever. And, but there is a very large part of the population that today relies on, either the government health space, the government health system, or on the informal private sector. And when we say private sector, really in that case, it's the informal health sector, right? So for them, it's not just an issue of, well, it's too much of a hassle to try and download an app because I'm going to go here. It's literally a
The
question
only way
of
they can, yeah.
It's a question of their livelihoods. It's a question, because about 70 million people fall into medical poverty every year just because of a medical incident in the family. So it's a question of, access. It's a question of life and death, literally, right? So being able to get access to the right kind of system at the right time, at the right level, is enormously important to a large hundreds of millions of people in the country. So when you today, it's extremely rigid in the way they access the system. And so by enabling this kind of digital transformation, you're suddenly going to make a lot of things accessible to them. Today, they will have to go to that particular primary health center. They have to go and, and everything is paper based. So it's extremely constraining, right? So when you look at it from their point of view, even to get care, they have to literally make the decision of, do I miss my daily wages today so that I can go all the way to the district hospital to go and access, go and get a checkup done, right? When people are trying to make those kinds of trade-offs, then having a system that's extremely responsive and that can allow them to sit in one place, access the system, get their health records with just a click of a button, access a doctor, get reminders, get, follow-ups. All of that kind of flexibility is just, life transforming for them. So I
I
think that's
think
the context that we need to look at.
you've hit the nail on the head. I think the two Indias, the privileged one that we all reside in, is essentially for us. Even UPI is not a necessity, right? Like life went on without it, but UPI enabled God knows how many crores of people to get money in
Yeah,
their banks for the first time. So
right.
so similarly here, it's for us, telemedicine is like a, it's just an option, right? But there are, like you said, hundreds of millions of people for whom it will be the first interaction ever with a health
Yeah.
system. And like, so that's a cool way of thinking about it. Thank you for sharing that. But then I'll just bring you in at this point, just again carrying forward the thought within, uh, you know be- in before the panel when we were talking, you kind of hit the nail on the head by saying that technology may not be the constraint, right? It's the associated business models that will drive sustainability of the technology that are maybe the bigger constraint. So in the context of NDHN, and I'm not sure how closely you've studied it, but assuming that Sunita's vision comes true one day, what would it take for people to build out successful apps uh, that actually make sure that the entire like the rails actually have trains to run on them, right? And they shouldn't just be or the highways actually have cars running on them. So would love your thoughts on that, and then maybe switch to Ajay, your thoughts on the same, since you've done
Sure.
some work on maternal and child health in that context. So Biten, please. You're on mute, Biten, sorry.
So first and foremost, oh, well, I'm still on mute.
No,
Can you
we can hear
me
you.
now? Okay, perfect.
Yeah.
So Sunita, thanks for sharing that. I think, that foundational aspect and bringing the concept of, laying down the rails definitely makes a lot of sense. And that takes care of the first big infrastructure gap, right? Which not just India, in every market will face or certainly faces when it comes to digital health. Vidur, when you talked about, how do you build apps, I want to pull back a little bit from that question and then come back to it in a moment. I think first and foremost, again, it's a perception issue, right? Just as I mentioned earlier, when we talk about digital, when we talk about internet, we almost believe it's free. So same way, when we talk about digital, we immediately jump to the concept of an app. And when we talk about apps, we again start thinking about the consumer centricity, which is great, and we need consumer centricity. But I would go back to a foundational level first, saying, okay, having laid down those rails, who is going to use it and what value is it going to bring to the stakeholders, right? In healthcare, in today's time, we always talk about the 5 Ps, or the 5 critical stakeholders, which is patients, payers, providers, policymakers, and the physicians, right? Whose problem are we solving with the technology, right? Because at any given point of time, these 5 stakeholders are engaging and interacting with each other, and there's a value transfer happening. So it's what is important is to get to the utility side of it. It's important to build these use cases. And these use cases have to depend on what problem are we trying to solve? Is it an enhancement and scaling aspect, or is it a gap filling aspect? And in that scenario, what are the transactions? What are the value transfers happening? And in the end, who's going to pay for it? So it's not going to be a one size fits all solution for everything. Just building an app is not going to be everything, but it's first and foremost going to be about identifying those use cases where you can then use this infrastructure, have a very central problem which you're trying to solve, and therefore being able to add value. And the engagement of either 2 or more of these stakeholders is critical. Now let's take that into an example case, right? Imagine this rail and infrastructure is laid out, okay? What does it take for a hospital to now go and start using it? They need to, patience is very clear. A patient sitting 500 kilometers from Delhi wants to get access to a cardiovascular specialist or a neuro specialist, would love to get an engagement with a doctor sitting in Fortis in Gurgaon or Delhi. Right? What is the incentive for Fortis, who's already having patients waiting for 3 hours in their OPD, to go and pay to access this infrastructure, right? So for them, unless it's a scale issue, right, or unless it can bring down their significant cost and shift their base, they may not adopt it. So I think what is going to be important for us all to remember is foundation and infrastructure is going to be important, but creating those use cases is going to be equally important, because some stakeholders might not see a benefit out of it. And therefore, the other part, which maybe we can touch on a time permitting, but I'd like Ajay also to dwell on. So I'll end it by the last point I'm saying is, let's not think about digital technologies just as app building. In certain cases, it might be playing a role of a simple role of being an aggregator. Because healthcare today is extremely transactional and fragmented. Even if we can use this infrastructure to aggregate the stakeholders together, it will open up a lot of use cases. It'll open up a lot more value adds across stakeholders and reduce the non-value adds.
So that's a great point. Yeah. Biten, and like I know for a fact that there's a lot of smart people at NDHM that are trying to figure out, what would it take to bring as you mentioned, a Fortis or a Polo onto the NDHM highway. And it's not easy to answer that question, right? Like there are like few examples are that your compliances become easier, like your certifications become easier, stuff like that. But it's also not the most lucrative, for lack of a better word. incentive to be able to do that. But let's see, time changes a lot of stuff, and I know there's a lot of smart people thinking about this.
Sorry,
Ajay, I'll just sorry.
I don't want it to sound that I was trying to be negative out here. I'm saying doing all this is absolutely critical, but in parallel, we all need to start thinking about those value use cases.
No, you're absolutely
Yeah,
right.
I think,
And I have like a crazy example, maybe completely silly only, but I recently got like a 1 Gbps internet connection at home, and I don't use it. So it's a great thing to have, but so sorry, Sunita, you were saying something.
no, I was just saying that I think that the idea, the big idea here is to suddenly open up to everybody. For patients, you suddenly have a choice. You have a
Yes.
provider choice, where you were limited to those few hospitals close to you, or the few, things that are very, accessible to you. Suddenly you have a huge choice. For the companies, for, the hospitals, right? It is, it's both scary, I guess, because it means also your patients could go away to another hospital, but it also means that you now have access to a much larger base than just your patient base, right? So I think unlocking is probably the key value proposition here, that for patients there's provider choice, for providers there is a much larger user, customer base that they have access to. And it kind of, democratizes, right? Because then you have a lot
Yeah.
more providers now who could come into the system outside of the formal system, right? And which is
No,
why I think as a
and
part
the
of this
payers as well, right? The
yeah,
payers
yeah,
get
yeah,
visibility
absolutely.
into various
Right.
providers.
And so the role of the platform here would be to provide the digital infrastructure, like certification, like, so that there is trust in the system. Because I think the whole thing would break if there's no trust. Why would I go, if I'm confident that I'll get a certain quality of care at Fortis, if the digital platform is not providing me that confidence that I can get that same quality from provide from some other doctor ABC, then I don't want to go there. I just probably, I'm not going to take chances with my health. I'll probably just stick to the Fortis doctor. But if through digital certification, through a whole bunch of other mechanisms, if they're able to build trust that, we know that this quality, and this is the way we gauge it, and this is the way we measure it, and this is how we share it with you, and we know there's also trust that my data is going to be handled properly, then suddenly I have a lot of options as a patient. So
Yeah.
I think that, yeah.
No, it's let's see how it goes. We're all rooting for it, and in our ways, trying to make it happen. Ajay, just moving you on, right? I think
Sure.
you please.
Sure. So I think I'll draw some examples from our day-to-day life and probably look at how we operate and work on a day-to-day basis beyond healthcare. So, for example, today I may have a bank account with the State Bank, but I can walk into any ATM, be it Citibank or any other bank, and I can actually withdraw money, and it reflects back in my bank account. Similarly, I have stopped carrying most of my credentials, be it Aadhaar, for example, or a lot of my degrees from the past, because I carry a digital locker in my mobile, which actually has a digital copy of it. And I don't have to, go hither and thither for trying to figure that out. I can just open my mobile and I have the data with me. And I think NDHM is actually at the base of it, enabling that through the infrastructure layer, a kind of personal health record, which will mimic a similar possibility in the future. Today, some of the challenges with regard to patient experience, if I've been to a hospital A and done certain tests, if I go to hospital B, I probably have to repeat them. And that is a lot of waste in the healthcare system, which, in my view, with the enablement of NDHM, for example, can be avoided. And of course, patient has to go through repeat scans, and this is, of course, a weight on his pocket, as well as a waste of time of healthcare resources, which can also be easily avoided. Now, imagine the possibility of enabling a DigiLocker, which a lot of people today use, to also start being used for healthcare report purposes, would be a great, segue, that digital technology can enable for people in India. And I think that's where we are heading towards. So basically, fundamental issues with regard to interoperability and access to information to better have access to care is something that this infrastructure is enabling big time, in my view. I think that's one aspect of it. The second aspect of it is today, because we do not have data, we also do not have accountability, right? We have a lot of volume based care, and the repeat scan is a great example where we are trying to increase the revenue and thereby the volume of doing procedures and scans. But fundamentally, are we really focused on the outcomes? Today, if I go out in the market for a certain activity or a certain thing that I buy, I mean, there is an outcome that is associated with that. In the healthcare world today, that is less prevalent. And if I look at the global world, there is a prevalence of something called as ICHOM standards, which is now standardizing care and the outcomes. And that is fundamentally based on data. So the digital infrastructure and our ability to actually collect data will make care a lot more responsible. And we will be able to at least benchmark how the care is being dispensed and basically measure the outcomes. And that's great both for doctors in terms of who are doing well and providers, as well as for patients, because they have a choice today. And I guess and I believe today that choice is quite limited. So that's one paradigm of shifting from volume to value-based care on the basis of digital, making interoperability a reality, which is there already in many other sectors, but healthcare is a laggard there, that becoming a possibility, and thereby overall improving the quality and the ecosystem of care. I think if we also look at the underserved geographies, be it in India and probably in Africa, where we do a lot of work, I think digital is the equalizer, that can actually bring care to underserved geographies. And while, we probably mobile world is beaten to death and is probably omnipresent around us, I think it's also an all-pervasive tool that can be effectively utilized in serving the underserved geography. So, for example, 13% of world disease burden comes from Africa, while only 4% of, I would say, the care giving capability exists in that country. And to be able to bridge that gap, the only way you can do it is through digital. And an example I could give you is at Philips, we have something called as mobile obstetrics monitoring, a mobile app based system for care providers. The midwives who are actually between the patients and the caregivers and the primary health centers, which actually collects a lot of data and predicts high risk pregnancies, which can get due, I would say, offer from the physicians out there in order to prevent any kind of premature deaths there. And I think digital is at the heart of it. And I believe that we are getting more and more into a very connected world where we will see a lot of things being connected around us and we cannot escape it. I think embracing is the only way forward, in my view.
Oh, thank you, Ajay. And those are all very, very pertinent points. It's just that, and again, sorry, but sometimes, I just can't wrap my head around, as Biten said, getting somebody to pay a maintenance for their iPhone is actually easier than getting somebody to pay maintenance for their, pacemaker. So do you really think that, people people without the additional you know uh, stick from somewhere else are actually going to use things like health record vaults and stuff like that, because that and I am guilty of it myself, right? Like you know uh, running supposedly a digital health company and organization, and still, like, if you were to ask me, Vidur, what was your hemoglobin the last time you got a blood test done, I'll probably have to, it'll probably be on a WhatsApp to my wife or something. So how does one think about that incentive of bringing the patient uh, into the entire game.
Absolutely. Yeah, I'll probably give my 2 cents and then, of course, open it up. See, the way that you explained is, as human beings, we all take the path of least resistance, right? Probably WhatsApp is the least resistance way for you to actually communicate with your loved ones, and that's the reason why we choose that. Which also tells us that a lot of these solutions that we have today have a lot of friction in them. I mean, today, if I have to carry my 2-year-old report to show what was my situation 2 years back, and there is a repeat occurrence of it, I probably will not be able to figure it out, simply because managing that is not possible. And however, if it is there digitally available, which is probably lesser resistance for me to open an app and figure that out and find that report, I may resort to that. So at the end of it, it all comes down to how we design our products and what is the user experience around it and how much friction can we reduce. It's not just about pushing technology, it's also about looking at human aspects around it to make it very usable. And I believe that's where lies the crux of adoption of technology. And it's not just about technology being there and pushing it for the sake of it.
I can build on Ajay's theme out here. He touched on two very, very important points. One is the human factor side of it, and about the friction or the resistance. Let me cite 2 examples, right? One from the healthcare world and one from the consumer world, and hopefully that helps bring the story together. But let me start by saying that the key message from these 2 examples is going to be it's going to be a journey. It's not going to happen overnight. And it's going to require not just investment in technology, but it's going to require investments in businesses before they become sustainable. You're not going to see profitability overnight, right? We all know even Amazon has taken years to get to a profitability level. And in India, despite they having beaten Flipkart today, they're still burning a lot of cash, right? So that's a reality of any digital business. So healthcare is going to be no different, and more so because the scale is unlike consumer products and consumer services. You take an example of something like, Make My Trip. Sorry, forget Make My Trip. Take the example of Book My Show. I don't know when was the first time any of you, my guys, may have used it. Today, every time you book a ticket on it, you're paying a convenience fee on it, right? And that is anywhere between 25 to 50 rupees per ticket, depending on which show you go. And of course, pre-COVID eras. But I had the pleasure of using it maybe 8-10 years ago for the first time when they started. They did not charge a convenience fee. It was completely free, right? And that was the stage when they were probably making the least money as a startup. They were burning cash. And they were addressing a critical problem where, number one, you had a hit and miss chance. You went to a theater, you might not get a ticket, and then you didn't have time to go to the next theater. Here, sitting in your home, you could not only choose the movie, you could choose the theater, you could choose the time slot, get your choice of the seats and the row, and by the way, be 100% assured that even if you reach just 5 minutes before the movie, you have your seat in hand. So a significant human factor and consumer challenge being addressed. And yet, when they started, there was no convenience fee. It took time for people to get aware about it, get adapted to this new way. And when they started seeing a value and when it reached the point that, now I cannot live without it, that's when the model flipped, where they're not only earning from the theaters as a percentage of the seat cost, but they're also charging the consumer a convenience fee, right? Same thing is going to happen in healthcare. There is going to be a time when the journey will evolve. Stakeholders will start seeing a value proposition. You'll have to start with a value proposition for one stakeholder, either a buyer or a seller, and then eventually it will move forward wherein both parties will see value and both parties will be willing to shell out money. In healthcare today, we will live in a world where insurance companies are saying, I care about the outcome. I don't care about how you deliver it. Whether you deliver it through a digital platform or a physical platform, whether your health record is in a paper format or in a form of a digital record. I am going to pay for the outcome of your procedure, outcome of your health, not for this. But for them to see the value of all the certifications, authenticity of records, everything, it's going to be a journey. So we have to make sure that we stay invested in it and have the patience to make it sustainable.
That's a great point, and I guess a lot of the digital health companies, especially on the aggregator side, the 1mgs, Healthians, Practos, etc., of our country are somewhere building on that thesis, right? That one day you become default, similar to Uber, and we're all aware of how the VC world works. I'll just pause at this point, and we've started getting some questions from the audience. Once again, please feel free to just type whatever comes into your mind, and Irfa will transfer those questions over to us. The first question from the audience was, how can we incentivize different stakeholders for enhancing adoption and diffusion of digital technologies? I think we've covered this, but any additional thoughts any of you guys want to add, like concrete tactical things that developers of digital technologies can do to drive adoption?
Keep the user story, keep the value proposition in mind, have the use case, either add value by helping them scale or bringing more revenue, bringing in more patients, bringing in more consumers, or help reduce cost or improve access. Unless you have that very clear story, don't be a tech company, be a customer centric company. When you're doing a startup, be consumer, customer, patient, hospital centric. Figure out the problem you're trying to solve and use the technology as an enabler. Don't take pride in your technology and then try to find the use case after you solved it, after you build the technology.
Yeah. No, one of the things we try to say is that you can't build clinical technology outside of the clinic, right? So you have to literally get your hands dirty, try to sit inside a hospital, even if it's the waiting room, right? Just sit there and code away. You will see like 100 inefficiencies and problems that are waiting to be solved. Sunita, you had something to add, sorry.
Yeah, I was just saying that our context, like I said, I work on the government program, and so they have to use the software, right? If it's a government program, and the government staff, health workers, doctors, they're made to use it. But the thing is, it doesn't work if if they don't see, like what Biten was saying, if they don't see the value of using it, then it's not good. Even if they're mandated to use it, you'll just have a revolution on your hands, because people will just say, this thing doesn't work for me, right? I think that the point of sitting with the user and making sure you understand what their needs are is extremely relevant. We've spent hours with health workers, right? And rural health workers are people with the 10 standard education, so their digital literacy is very low. We work with tens of thousands of health workers, and many of them are using a tablet or a mobile phone for the first, mobile phone maybe, but tablet certainly for the first time, right? So their experience, of using this tablet, you have to put a lot of thought into it. And when you're working at a very large scale, you can't guarantee that there's going to be one-on-one training, right? Because things get diluted. You roll these out, these go through the government systems, and so you can't guarantee the quality of the training or the experience that the person is going to have. So you have to make it extremely user friendly. So when we put in a lot of thought into the design of these systems, we literally sit with health workers and make it, it's all local language, pictorial, very little typing, all of that stuff, so that when we roll it out at a large scale, it will work for them without much hand holding and support. But frankly, if they don't see the value, it won't work. If you're not solving their problem, like in the case of the health worker, today she's maintaining 50 registers, and she takes, writes down details on a daily basis on 50 registers. If you are helping her solve the problem of all that bookkeeping, right, of all the maintaining those registers, and making it easy for her to pull up a record, click, just search, write up a report, if you're making that very easy, then she'll use it. That's the bottom line, right?
Yeah. No, and we just got a related question, on the point you were just making, Sunita, which is, considering the huge population, where are we lacking in training the healthcare workforce and capacity building? I would say, where do we start with, training the healthcare workforce and capacity building? And I think this is more from a point of view of, adoption of digital technologies, right? So,
Right.
and my personal view is that you should ideally not need training, right? That's the level of adoption we should adhere to. Like my 90-year-old grandmother, touchwood, uses WhatsApp and like writes long messages to all of us all day long. And I can never figure. I didn't teach her. I in fact tried to teach my granddad. He couldn't learn. so yeah, would love your thoughts on the whole
Yeah.
training aspect. Yeah.
Right. No, so we are, I can talk from my example, but it's very similar to other government programs that are being rolled out, right? So there is already a very strong health system that is set up, right? That is delivering all these programs, with the people at the state level, district level, block level, taluka level, PHC level, down to the village level. So we piggyback on that health system. And so what we do is that, so there is a training of trainers, and then they train the next level, and then that cascades down. But having said that, it has to be extremely, so that's the ease of use part, right? We make it, like I said, it's all completely in local language, pictorial, so it should be easy. The other thing that we have in our system is that when the government mandates this, then there's a heavy push with the current government to make everything go digital, right? So it's built into their plans. It's built into government, so government has something called PIP. These are your annual plans. And so they basically, into that, they incentivize. So they basically say that if you have to get your budgets for this year, then this much of digitization has to happen, right? So those kinds of things, so both the carrot and the stick in a way, right? You have to, so those measures also help to ensure that there is adoption on the ground. But what I've found, and I've trained, like, I think at least maybe close to 1,000 health workers myself over the last 7 years. I think it's not just a one-time training, right? And I'm sure everybody knows that it's not just a one-time training. Think about the background that these people come from, and for them, digital has to be a tool. They still have their daily job, and that's a huge amount of effort. So this has to help ease their burden, and they can't devote a whole lot of time on it. So they need, just like you would sit with a child and cajole them to get, to develop a love of maths, and keep training them, and over and over and over again. This requires a lot of training, retraining, hand-holding, support. So we put in a lot of thought with Tata Trust on what is the support mechanisms. How do the L1 level, the L2 level, the L3 level, how do people reach out if they have a problem, and make sure. So I think if you spend the first 6 months, 1 year in helping them have a good experience, both in multiple trainings and in the support when they do have a problem, once they get it, then it's fine. Then you can put out new releases and all of that stuff, and then they're like, or many of them become real experts in this.
No, I
Right?
guess it's about habit. Sorry, within.
No, go ahead, Vidur. I was just going to add to Sunita's point, but I'll hold on if you want to finish your point.
No, nothing. Please.
Yeah, I was just going to say that we need to change our mindset, and we need to take a two-pronged approach out here.
Who is we, Biten?
We, as in at the system level, and I would say more specifically at a policy level. Okay, we need to engage with the government. It's great to have, India government doing something very unique when we talk about NHDM, right? Most countries haven't tried it, and that too at a scale of India, it's commendable. But that's one aspect of it, right? That is about, bringing in more capacity and bringing in, ease of implementation through this platform. Okay. And that's a great way to, attack this problem about even training of healthcare workers, right? You can protocolize it, you can share the existing knowledge and bring it down to the last level and make the training module and the knowledge accessible. But I think we also need to change our mindset that we are not going to solve it and build a scale if we just think the classic way of building capacity. And that touches to what you mentioned earlier, Vidur, which is, do you really need a trained set of manpower? Or can you make do with de-skilled manpower, which is enabled with technology, right? So digital is not just about, building the app again. Digital is also about using ML and AI, right? So do you need a doctor at site, or do you need somebody who's trained even to be a trained nurse to be at site in a rural primary healthcare center? Or can you have a baseline technician who can manage and use certain sensor-based equipments, even build on a mobile phone or a mobile portable platform just to capture the basic information which a doctor utilizes to make the right decisions, and then use cloud, AI, ML technology to do the actual diagnostics. So we need to tackle this at two-pronged levels. Certainly, we need to bring down the existing knowledge and train more people and scale the training part, but we cannot only rely on that. We need to be thinking.
No, absolutely, Within. And I think what Sunita's point, and I guess all of us agree, is that only once you have that infrastructure in place will you even be able to start deploying any of these solutions, whether it's through a skilled or an unskilled person. The thing is, Sunita, you briefly mentioned this aspect of the government making it mandatory for at least its workers to use the technology, and that plays a major role as an incentive. And I think, even though it might sound counterintuitive, I think sometimes that's the only way to go ahead, right? Like, and I use this silly example of seat belts, right? Like, where everyone knows seat belts saves lives, but everyone wore a seatbelt only when there was like ₹100 challan for it. So sometimes as humans we do need, and the same thing, you can now talk about masks. In New Delhi, they literally increased the fine from ₹500 to ₹2,000. So I think sometimes we do need that stick. Of course, you need to be right about about implementing the stick. I think I'll switch over to another question, and maybe Ajay, this is best answered by you, but of course others also chime in. It says what India needs is value-based healthcare, as you were mentioning, not just cheap healthcare. But how do we ensure effective and value-based running of primary care centers in rural India, right? We typically associate value-based care with higher end interventions and complication rates, and how many days, reinfection rates, and all of those things related to fancier settings. But how would one think about value-based care in a OPD rural primary healthcare kind of setting?
Right. So I think a couple of things. One, to mention that the care settings today are undergoing a rapid change. I think we have tier 1, tier 2, tier 3 cities. And typically, I would say, because of the economics of what goes in for doctors to actually reach the scale that they do, and where they can actually monetize what they learn, you will find most of the practitioners actually tending towards tier 2 and tier 3 cities. And that poses a big challenge in the tier 3 and the rural settings, where simply availability of a trained doctor or even a nurse or doctor per population is actually very, very skewed. So I think that's one paradigm that we repeatedly see around us. I mean, for example, I'll take an example of critical care where an intensivist is required to oversee an ICU. And today, I can find quite a few intensivists in the tier 1 cities. But the moment I have to oversee or get an intensivist in tier 2 or tier 3, I just have to probably fall back on a nurse doing that job. And technology comes to help there. For example, we have a solution called eICU, where a cockpit-based approach towards managing an ICU from a tier 1 city into a tier 2 or a tier 3 location is today now possible. There is a very innovative business model moving away from OPEX, rather from CAPEX to an OPEX-based model, where people adopting such solutions don't have to pay upfront, but as they operate and as they earn, they can continue to share their part of revenue with the creators of these solutions. So one, again, I think technology comes to help, because if there is no connectivity, there is no storage possible for information, this would not be possible. And secondly, being trained people available in tier 1, tier 2 cities, and extending their reach towards tier 3 and probably even villages is something pretty unique, which is now possible today. And I think that's the way to go. So more and more companies like us and even startups need to think of how to not make geography a limitation, but use technology to bridge that gap in helping care reach the furthest part of this country.
Got it. No, thanks, Ajay. And just again taking on that point, because I actually find this question to be quite interesting. Sunita, in your experience, like, is there any way in which the government or someone is trying to see the efficacy of care being delivered at the primary healthcare, like at the
Yeah,
Ayushman
yeah,
Bharat wellness
yeah.
centers? Like, how does that
Oh,
work?
definitely, definitely. I mean, again, I'll talk from our experience. So, under Ayushman Bharat Health and Wellness Centers, there's a package of 12 services, maternal child health related services, communicable diseases, TB, leprosy, non-communicable diseases, geriatric palliative care, all of that stuff, right? So the way the Health and Wellness Center program scheme is designed is that there will be outcome indicators for all of these, and the entire the funding mechanism for these health and wellness centers, including incentives for the health and wellness center staff, will be tied to these outcomes, right? So in the case of NCD, as an example, you would look at things like how many people were enrolled in the program, because it's supposed to be a population based program. Every individual over the age of 30 should get screened. So what percent against the denominator of the population for your health and wellness center, which could be around 5,000 people, how many people were enrolled? Out of them, how many were screened for all of these diseases? Out of the ones screened, how many got referred for higher levels? Out of the people who were confirmed for, let's say, for the hypertension, how many are actually getting, follow-up visits? How many are having their BP under control? Right? This is just an example for one of these
Wow.
things. And
So, but
BP under
are all of
control
these
will
things
require
going to
that
be
they're taking their
monitored?
medication. Exactly. And this is why
Wow.
digital is so important. Doing it on paper is doable, but all the disadvantages of doing it on paper, because then people are just reporting some aggregate numbers, very hard to get visibility into, are those actually right? How do you actually monitor, right, whether all of these things are right? So increasingly the realization that digital will allow, especially if it's down at the point of data entry is digital, then the quality is much higher. It's not collected on paper and then some aggregate numbers being sent off reports to Delhi, right? So by having digital right at the point of collection, at the point of service that's being provided, you start, and then you start aggregating it. You provide reports, and analyze the analytics and all of that stuff. You can actually draw out these kinds of indicators, and that's the vision, that eventually you should be able to look at what is the level of control that's being achieved for NCDs, what is the level of immunization that's being achieved, what is the institutional delivery rate, right? And then those are the outcomes that you want, and those are the ones that are going to determine. And of course the big thing here is, of course, the drug availability. Studies have shown that
Yeah.
people will go to a primary health center. Biggest determinant is if there are drugs available. So
Yep.
monitoring that through digital and ensuring, and getting a trend of, what drugs are available, what percent of the time, what is the unavailability, and all that stuff, all of these will help improve the quality, as including the staff attendance and their presence in the center. All of these, they're very, there's actually a lot of thought that's gone into understanding what makes a primary healthcare system function well, and what would draw people into a primary health center. So monitoring that digitally, I think, would provide this.
Oh, great.
Yeah.
And yeah, Ajay, sorry.
Yeah, so I just wanted to add a point. I think the whole vision of health ID linked to NDHM is also very unique, because that is what will leapfrog us to actually get to an individual case. I mean, today, for example, if COVID
Right.
vaccine would come, we would have no way of tracking, who got it or who won't. But
Yes.
probably 5 years from now, when health ID would be there, I think we would have an excellent mechanism to track this. And health ID would
Absolutely.
also become the vehicle for population-based management of health. And I think NDHM, along with health ID, is something that will transform the health system locally in India, and at least at all levels, in my view. Yeah.
Yeah.
Sorry, Dr. Sunita, sorry, you wanted to say something?
No, I was just agreeing with
Sorry.
you.
Great. So, no, we have one, very interesting. Of course, we have this one very tactical question that's just come in, which we've deliberated. I'll still read it out. It's like, as a startup, how do I convince a patient to pay for digital tools for maintaining their health records, just rupees 1,000 per year? I think that's more than what Netflix charges or what Amazon Prime charges, right? I really wish I had the answer, but any of you guys wants to answer that?
I'd
Or
say it goes back to the example which I gave about
yeah,
Book My Show, right? You will get to a stage where not 1,000, they might even pay 5,000 as an annual fee.
yeah,
But you've got to first create the use case of a few critical, willing to pay consumers or willing to use customers come on your platform and learn from them.
Yeah.
How much are you able to retain them? If you can get your first 100 on your app, and then even though they're not willing to pay you, if you can figure out a way to keep them for the second year,
yeah,
or charge them in year 2, you'll have a tremendous learning, which might even open up opportunities where you might be able to charge not 1,000, maybe 2,000, maybe 5,000. But getting the first willing to use customers is so critical in most businesses, and it's not going to be different in digital health.
No, ask me. I've been trying to sell, 1,000 rupees USB drive with somebody's PET CT on it, and it's impossible. So,
As I
but
said, pacemakers,
yeah,
people don't pay for things which keep them alive every breath,
correct.
every
But
heartbeat.
I also think that this is, and we could keep talking about this all day, night. But it's important to segment who you're going after, right? Like, so when we see cancer patients carrying around like this big lifafa, which is filled to the T with reports, like if somebody was to go to them and maybe say, hey, I'll create like your entire Janampatri of cancer, right? Maybe that is something that is valuable, and I'm sure
Value,
it's
the
valuable.
early adopter
So
value. You got to find that
correct,
subsection of early adopters may not be your biggest
correct,
segment, but
correct,
that is the
correct.
segment which will set you rolling.
In
One
general, I
more
think,
question. Sorry, Ajay, please.
sorry, very quickly, I think one more thing to realize is India in general in healthcare is a repair market, right? I mean, by that, what I mean is I would not go for a proactive dental checkup, but if I get a caries or some other issue, yeah, I have no choice. Then I have to go and get the procedure done, which is more painful. So in general, I think that also plays out in the psyche that we have in the society, that we don't want to pay proactively for well-being, but we are very reactive here. That's just the reality of where we are. But hopefully, digital can change it. But that's also a challenge for the businesses and startups as well.
Correct.
Yeah.
In fact, just to add to Ajay, the other part here is also about trust and awareness.
Yep.
You got to be aware about alternative options, and you got to be able to trust alternative options. If you cannot give them that trust, then even free may not get you adoption.
Yeah.
Correct. So just taking on this next question, which is very interesting. I'm not sure if you guys see this trend also, but even in COVID times, post lockdown, people in India are going back to OPDs instead of continuing with telemedicine. Is that true? Do you guys see that, like from your vantage points?
Actually, I was on another panel a couple of months back, and we had a co-founder of one of the telehealth companies on the panel. And her experience was exactly the reverse of the question here, where she said that originally they built the platform for telehealth, focusing on the semi-urban and rural population to give them access.
Yeah.
But what they've seen during COVID times is actually a heavy adoption from urban areas, because COVID again became an equalizer. It didn't matter where you were, in what part of the world you were, whether you had money or didn't have money, you didn't want to go out of your house, and yet you had to have health consumption. I've had several friends reach out to me asking that my dad is old, has dry eyes, or wants to check the cataract. Can the operation be postponed? Is there somebody in Mumbai or Delhi or Chennai who can do a telehealth review of his eye health? So actually, for the people who have been aware and have been able to gain the trust on the platform, have actually adopted more, and more so in urban areas. Now, those are the people who might stick on.
Yeah. No, and I also think that, maybe the person who posted this question, there may be a little bit of bias in there, because, obviously there are majority of, or not majority, but a fair bit of consultations are best done physically, right? Like the whole clinical examination part. So maybe, those went down during, the lockdown period. And then, telemedicine brought up, the somewhat, less intense consultations. And now we see, those more intense consultations coming back. So as a percentage, you see a drop. So one would have to, really go into volume rather than relative numbers.
Correct. Vidur,
through this.
it's also about the clinical stage, right?
Correct, of course. Yeah.
If you, there will be certain procedures which, because of lack of infrastructure and diagnostic tools,
Yeah.
and even acute care procedures, it cannot be given at home. Although that's also moving, right? Today ICUs are moving into homes. So at least the first gap is screening, right? 50-60% of the primary health is you're going to a doctor, and the only thing he's probably using is a stethoscope and a thermometer and a BP tool, and these are available for home use. So you can use it under their guidance at home and finish those parts of those type of telehealth consultations.
Got it. So, guys, we have like literally 8 minutes left. I think would love to hear some closing thoughts from you. As I had mentioned, before we started, that something actionable, right, in your respective fields. People who are listening to this session, what can they do in order to drive digital adoption, or ensure that care is truly accessible, affordable, equitable across the paradigm. And maybe we'll go ladies first again, Sunita, and if you could start any parting thoughts, and what people can do in a actionable kind of way.
Yeah. No, I'm extremely bullish about the environment we're in and how technology can be built and driven and adopted. I think all the stars are lined up well to make it happen. So what I would say is, what I started off with is that uh, given the huge problem with fragmentation and lack of interoperability, we should ensure that we go in with our eyes open. Anybody who's getting into the space, make sure that when you build stuff, you're complying with the existing standards, you're building on the existing platforms, because this whole problem of two people sitting in a garage coming up with an app, and like that, there's a whole profusion of apps which then don't talk to each other. We've got to end that. So the one thing I would say is, the time is ripe. Go out. We need like 1,000 flowers to bloom. You need lots of people to come out and build stuff, to innovate, but build on the existing platforms, the standards, things that are already out there. Use those, because then it's going to make it much easier to to become a part of the ecosystem and leverage all the other leverage the strength of everything else that's happening in here.
Got it. So don't build in silos, build on existing infrastructure, use existing tools, use and do that
Standards.
from day one. Learn about FIRE and HL7 and all of these cool things, and NDHM, and don't just get a app idea and start building it. It's like that.
Yeah.
Great. No, thanks, Sunita. Biten.
Sunita covered some really extremely good points out here. I would say I'm going to be the first one to build on that. As she said, we got to build on what's there. So I'd say again, focus on the problem you're trying to solve. Focus on delivering value. Don't take pride in technology. Take pride in solving the problem. And I'd say the other part is challenge the existing mindset and existing processes. While you want to stick to standards, but do not be shy from challenging the existing mindset and existing ways of delivering healthcare, because we got to try it from both the ends. We can't just keep trying from one end. There are enough problems to solve, and of course, the future is bright for India. More so, not just because we have immense amount of health problems to solve, but also because we have tremendous talent, both in terms of clinical talent and in terms of technological talent. And I'd call out that stakeholders, if there are stakeholders, be it patients, physicians, providers, hospital, administrators, I think everyone needs to keep an open mindset rather than being scared and concerned in the short term about losing their current business or losing a patient or losing the next revenue. If we keep ourselves open, just like we had a leap of faith in mobile telephony making huge penetrations, digital health can be the next big one for us.
All right. Thanks, Biten.
Awesome.
Ajay, please.
Yeah. So I think in my view, the right care at the right time in the right place, and that's for me healthcare without bounds, which digital can enable. I think in our continuing efforts to increase quality, decrease cost, and improve the overall patient experience, digital will enable an Uberization of healthcare in coming years in India. Specifically, what startups can do, for example, what was mentioned by Sunita, NDHM stack is already available for use. So people who want to start playing around with APIs, there is a sandbox that is available, and that can be picked up for use. And I think second actionable thing is healthcare can draw a lot of relation from other industries, and specifically, I believe from the financial world, a lot of parallels can be drawn, in my view, specifically around interoperability of data, how to handle data, and how finance is so intricate and so important, so is healthcare. And I think, mixing and matching of ideas from one field to the other is something that will provide tons of opportunity in healthcare. So I see, again, like it was mentioned, pretty invested in digital and looking at healthcare evolving in India. Thank you.
Oh, great. Thanks, Ajay. And, I'll just add my 2 cents to it. I already said it. If you're a technology developer wanting to build healthcare stuff, please do it within the healthcare environment, right? Like try to spend as much time as you can with your user, with your customer, with your stakeholders, right? It's very easy to fall into that trap of I faced this problem at a hospital, and hence maybe it is a generalizable problem. So don't fall into that trap. Spend time with them. Doctors are immensely amenable to using technology. There is this prevailing thought that doctors don't use technology. This that like I think the amount of care again is delivered through WhatsApp is just ridiculously high. But it's just the barrier to using WhatsApp is ridiculously low. So it's and we see this in radiology, right? People have set up crores and crores worth of teleradiology systems, and at the end of the day, people are just clicking pictures and sending them over WhatsApp, and diagnoses are being made. Right or wrong is an entirely different debate. But so doctors are extremely amenable. It's just you have to make life easy for them. And spend time with them. And lastly, as Biten and Sunita said, build on NDHM. Ajay also mentioned the NDHM sandbox is very much available. We play around with it a lot, and the APIs work, everything works. Play around with it, and let's build this ecosystem together. Let's also build for India, and disseminate then to the rest of the world. So with that, thank you so much, Sunita, Biten, Ajay. Thank you to the HitLab team. Irfa, you can take over. Thank you so much, guys.
Thank you, Vidur.
Thank you, Vidur.
Thank you. Thank you, Vidur.
Thank you
Irfa.
to all the panelists for the engaging session. It was indeed a pleasure to witness the discussion, and I'm sure the audience could draw valuable learnings and insights from the discussion. Thank you. And I would now like to move on to our next session. We have Jessica Howards, founder of NERCS, to talk on women's health tech. We will begin shortly. Please stay tuned. Thank you. Bye.
Thank you.
Pleasure talking to you guys, Ajay, Sunita.
Yeah.
Likewise,
Nice
Biten.
talking to you,
Thank you.
Biten, Ajay. Yeah. Thanks, Vidur.